Hello and welcome to the studios. This is the latest in the IHS research series, and today we're going to look at two clinical guidelines from the National Institute for Clinical Excellence. The first guideline is the use of newer atypical antipsychotic drugs in the treatment of schizophrenia. The second is core interventions in the treatment and management of schizophrenia in primary and secondary health care. I'm joined today by four colleagues from the local health community: John Rawlinson, Andy Carbery, Mike Snelson and Nick Booth. Each will give a short introduction on their interests and activities before the presentation starts. John.
Yes, hello, I'm John Rawlinson. I'm the academic lead in mental health within the Institute of Health Studies. My background is as a CPN. I run the qualifying course for CPNs, the Community Healthcare Nursing course for mental health, and the MSc in mental health.
Hi, my name's Andy Carberry, Senior Lecturer in Mental Health based in Taunton. My particular interest in the topic today stems from some involvement in medication management in psychosis and the subsequent development of some courses to cover that, and in cognitive behavioural therapy, which I'm involved at the post-registration level.
I'm Mike Snelson. I'm a consultant in general adult psychiatry in Plymouth, and I work as the senior medical member of a community mental health team, providing in psychiatric interventions for a sector which is about a fifth of the population of Plymouth.
Hello, I'm Nick Booth. I'm Head of Psychotherapy Services in Plymouth Primary Care Trust, and by profession I'm a clinical psychologist and family therapist.
The session today is in two parts. Firstly, John and Andy are going to provide an overview of the two documents we're discussing, and then there's a discussion involving the audience in the various centres that receive this broadcast. For those people who wish to participate in today's broadcast, I have a telephone number which is Plymouth, which is 01752 233 646, or alternatively you can email on TV Studio, that's just one word, at plymouth.ac.uk. Well, without much further ado, I'm going to ask John to begin the presentation. John.
Hello. The presentation today concerns two documents from the National Institute for Clinical Excellence. The first is the new clinical guideline on interventions for the treatment and management of schizophrenia, and the second is a technological appraisal, which is guidance derived from looking at a specific intervention, the newer atypical antipsychotic drugs. First of all, I'm going to give an overview of the guidelines, and then Andy Carbery is going to review the evidence that underpins them. I'm going to start off by talking a little bit about the context of these guidelines on schizophrenia, starting with a reminder that the care programme approach has been the underpinning way in which mental health care has been delivered since 1990, although it was implemented a little bit later than that. We had the initiative The Health of the Nation in 1992, which tended to focus on severe and enduring mental illness, and in particular suicide risk. There have been various attempts to provide guidelines for the treatment of schizophrenia. There was an attempt in 1995. The Clinical Standards Advisory Group provided some guidelines on schizophrenia. They've been developing a body of evidence in relation to some of the interventions which are included in the guidelines, and these are family interventions, psychosocial interventions, developments in pharmacology, in early intervention, and in assertive outreach. These have been going on prior to the guidelines. We're in an era of evidence-based practice, evidence-based medicine. I guess the last decade has perhaps characterized an emphasis on this aspect. been characterised by the release of various effective healthcare bulletins, Cochrane reviews, contributing to the evidence. And then we had the National Service Framework for Mental Health in 1999, which started to set out the standards which would be provided within mental health services. The British Psychological Society contributed to our understanding of the experience of psychosis by a very useful document which summarised the understanding of schizophrenia and psychosis. And then we've had a range of mental health policy implementation guidance, first of all in the original implementation guidance for the National Service Framework, and then a series of other specific guidance, or PIGs as they've become known, around specific services such as services for women, acute inpatient services. So, as I say, the two documents we're looking at, first of all the technical appraisal of the atypical antipsychotics, and then more recently this first clinical guideline that's been released by NICE on schizophrenia. If you haven't got the documents, you can download them straight from the internet from the NICE website. You can order them from the NHS response line, or you can order them by email from the Department of Health. So the question is, can we make these policy initiatives, these policy implementation guidelines, a reality? Let's look a little bit at the background to schizophrenia and some of the outcomes. Perhaps the least publicised is that in fact something like a fifth to a quarter have a single diagnosed episode with no resulting clinical or social impairment. Something like 35% have occasional recurrences with no or minimal impairment between episodes. About 8% experience some impairment after the first episode, and that persists unaffected by further breakdowns. But some 35% are increasingly damaged by each subsequent acute episode, so that their social functioning worsens progressively. Need to be aware that with the current services, something like 50% of those who are treated by standard services require a further admission within the first 2 years. And this is in the context of, in most studies, something like a 1% lifetime risk across the general population and across all cultures. Some other outcomes that perhaps we should remember about schizophrenia. First of all, the negative social reactions to symptoms and behaviour that people encounter, which have consequences such as stigma, high unemployment, or failed or impoverished relationships. That people who have schizophrenia have something like a 10-year shorter lifespan than in the general population. Around 10% of those who have a diagnosis of schizophrenia go on to commit suicide. And they're also at a significantly higher risk of accident or cardiovascular disease. So if we look at the guidelines, some principles are very clearly outlined. First of all, that the services should be characterised by optimism. This is quite a change from perhaps some of the attitudes that people will have met in the past in relation to having a diagnosis of schizophrenia. That the services should be characterised by getting help early. That it should include a comprehensive assessment, not just a medical assessment, a comprehensive assessment, medical, psychological, occupational, economic, physical and cultural. That it should be characterised by partnerships between those who are using the service and their carers and the providers of the service. That it should be characterised by informed consent and good attempts to engage with the client. And that there should be good, clear information and mutual support provided. That it should be in a language and an understanding of the culture from which the service user comes. And there should be attention paid to any advance directives that the service user wishes to make. For the purposes of the guideline, it's divided into care across 3 phases. Firstly, initiation of treatment at the first episode. Secondly, the care and management of the acute phase. And thirdly, the promotion of recovery. So if we look at the initiation of treatment at the first episode, first of all, referral. Anybody who has a suspected or newly diagnosed schizophrenia or a presumed diagnosis of schizophrenia should be seen for assessment by a consultant psychiatrist. There should be early intervention. There should be early intervention services available, and where these can't meet the needs of the service user, easy referral to other services which should be available within the locality, and these include crisis intervention services, home treatment services, acute services and inpatient services. But pharmacological intervention should be available, and these, for a first presentation, should now include atypical antipsychotic drugs as the treatment of first choice for the first episode at a low end of the standard dosage. That a second opinion should be available should the service user choose to seek one. If we look at the treatment of the acute episode, then it's characterized by a range of service level interventions, which I'll talk about in a moment, by pharmacological interventions, by a broad range of social, group and physical activities. It may require use of the Mental Health Act, or inpatient treatment may prove necessary. And the services that should be provided, and these are now beginning to characterize mental health services in local providers, should include crisis resolution services, home treatment teams, early intervention services and services for young people, assertive outreach services, community mental health teams, acute day hospitals, and inpatient care. If we look at the acute, early post-acute period, then this should be characterized by a focus, a user focus, by ongoing assessment, by the availability of psychological treatments, including CBT and family work, and by clear advice about medication, not just the prescription of appropriate medication, but its support by good information and good advice. That there should be an emphasis on the promotion of recovery by both primary and secondary services, and that there should be ongoing work in relation to preventing relapse. It should be both psychological and pharmacological. Again, looking at the post-acute phase, there should be help available to service users to understand their period of illness, to have an opportunity to integrate it and to write an account of their experiences in their notes. Carers too may need help in understanding the experience that their relative has gone through. And there'll need to be further assessment for further help, which will help minimize the impact of their disability, to reduce the risk of relapse, and to improve their quality of life. Also in this period, there should be psychological and family help, contingency planning against relapse or crisis, and the identification of local resources, local services. There should continue to be good, clear advice about drug treatments to help maintain compliance and recovery. Recovery is a word we hear a lot of, but it needs to be promoted across the services, both in primary and in secondary care, characterizing the range of service interventions outlined, providing psychological interventions as well as pharmacological interventions, and also emphasizing and helping people to appropriate employment. Just mention two specific psychological interventions. First of all, cognitive behaviour therapy, and it's recommended that cognitive behaviour therapy in particular should be available as a treatment option for people with schizophrenia, and there's a developing body of evidence, which Andy will talk about in a moment, which underpins this. And in particular, CBT should be offered to people who persistently experience psychotic symptoms. And then family interventions, another area of growing good evidence. Family intervention should be available to those families of people with schizophrenia who are actually living with or in close contact with the service user. So a little bit more about the pharmacological intervention across the phases. First of all, there needs to be a recognition that antipsychotic drugs are likely to be necessary. That service users should be able to make an informed choice of antipsychotic. That single drugs, single antipsychotics should be used using doses within the BNF range. And that the clinical response and the side effects should be monitored routinely and regularly. Oral antipsychotic drugs should be considered as the first treatment of choice. The dosage of conventional antipsychotics should be within the BNF range. The reasons for any doses outside the range need to be documented, and the minimum effective dose should be used. But with conventional antipsychotics, if side effects are troublesome or symptom control inadequate, then an atypical should be offered. A couple of further points about the pharmacological interventions. First of all, massive loading doses, rapid neuroleptization, should not be used. We're talking about using the lowest dose to begin with. Although rapid tranquilization may be required in the acute phase in an emergency, and if this is the case, then the specific drugs are recommended. Pharmacological intervention clearly has a role in the recovery phase, particularly in relapse prevention. Antipsychotic drugs are an indispensable option for most people in the recovery stage. People may aspire to becoming drug-free, but there's a recognition that they're probably likely to be indispensable. The choice of antipsychotics should be entered into jointly by the individual and the clinician. And antipsychotic therapy must be seen as part of a comprehensive package of care that includes and addresses clinical and emotional and social needs. Some further points about pharmacological intervention. If depot antipsychotics are to be used, then clear risk assessment must be performed and documented, and the initiation of the depot antipsychotic injection should take into account the preferences and attitudes of the service user. That's both in relation to the drug to be used, if the person's perhaps had several depots before, and also in relation to the site of injection. Finally, in relation to pharmacological intervention, if we're referring to treatment-resistant schizophrenia, then antipsychotic drugs must have been adequately tried, both in relation to their dosage, the duration, and adherence. In order to confirm that somebody should be described as having treatment-resistant schizophrenia, then atypical antipsychotics must have been included within their previous treatment. And at that stage, treatment-resistant schizophrenia is recognised, and the use of clozapine is recommended within the guideline. I'm now going to hand over to my colleague Andy Carbery, who will review the evidence that underpins this.
Hi, thank you, John. Okay. Now, before we consider the evidence, it's worth referring back to the grading of evidence that's listed within the within the documentation. With In respect of the use of atypicals, then within the publication for the core interventions, in the evidence column, then it lists the NICE 2002 as the reference. So all the evidence for the use of atypicals stems from the technical guidance publication that John mentioned earlier. In respect of the other two areas that I'll be looking at the evidence, then family intervention and cognitive behavioural therapy, then they are graded according to the types of evidence. So if it's a score of 1A, then the evidence for this is obtained from a single large randomised trial or meta-analysis of at least 3 randomised controlled trials, whilst evidence 1B is obtained from a small randomised controlled trial or a meta-analysis of at least of less than 3 RCTs. Turning to pharmacological interventions then, there were 172 RCTs reviewed with evidence from 29 head-to-head trials of typical agents. The typical agent here normally being haloperidol, which has attracted some criticism obviously because of its large range of side effects. In addition, there were 52 other studies, and these were considered which were either case controlled, had more than 2 years of follow-up, or included more than 2,000 participants. And the overwhelming majority of the RCTs were 4 to 8 weeks long, which is a relatively short period, with 31 being over 6 months duration. The fact to consider at this point is that most of the subjects that were involved in the 4 to 8 week long trials would have then carried over into the 6-month duration trials. So the considerations here then are that there are some limitations simply due to the lack of long-term follow-up, high attrition rates, and the inadequacy of the collection and reporting of adverse effects. This final point here about reporting of adverse effects has changed recently. The old yellow forms that we used to collect and collate data has been reviewed. And the high attrition rates could be subject to issues based around compliance. For example, Gray's research of, I believe, 2001-2002 found that relapse rates were as high as 50% 12 months after treatment. Haloperidol, which may be associated with a higher rate of extrapyramidal symptoms than any other atypicals, was used as the comparator in many of the trials, and still is with new drugs emerging onto the market. So the generalizability of individual study results was limited by the exclusion of several groups, for example, elderly people, as well as individuals with treatment-resistant schizophrenia, those with predominantly negative symptoms, learning disabilities, comorbid depression, and substance abuse disorders. The final one there being particularly of interest, as some current research in London indicates that the rates for substance misuse and psychosis can be as high as 80% in the comorbid study. So the evidence. Atypical antipsychotics are at least as efficacious as the typical agents in terms of the overall response rate. There's variation in their relative effects on positive and negative symptoms and relapse rates. And there's inadequate data to enable separate evaluation of the overall impact of individual atypicals on schizophrenia. So the evidence continued has all atypicals are associated with a reduced incidence of extrapyramidal symptoms compared to typicals in the short to medium term. This is up to 26 weeks. In the long term, which is 26 weeks or longer, again there's limited data to support a reduced incidence of extrapyramidal symptoms with some of the atypicals. However, it's worth considering that with some of the atypicals there can be an incidence of extrapyramidal symptoms once you get towards the higher dosing ranges. There's little evidence of comparative rates of tardive dyskinesia between the atypicals or between the typical and atypicals. And the side effect profiles of individual atypicals may differ, but definitive statements relating to differences between them are difficult to make because of variations in the evidence base for individual drugs and in the length of treatment follow-up. As John mentioned in his presentation, with clozapine, The evidence suggests that in individuals who have not responded to previous antipsychotic therapy, then clozapine is associated with fewer relapses and greater clinical improvement than typical agents. So the recommended drugs that appear within the NICE guidelines are amylsulpride, olanzapine, quetiapine, risperidone, and zotapine. The interesting thing here is these are the ones that the psychiatrists are recommended to use by virtue of inclusion. However, there are still new drugs emerging on the market, and it will be interesting to see their impact. Moving on to cognitive behavioural therapy, the total of 13 randomised control trials were included in the review. These providing data on 1,297 participants. All in these trials were also receiving antipsychotic drugs, and most often CBT was targeted at individuals with long-standing or treatment-resistant psychosis, and the control groups received what was called standard care, recreational activities, befriending or supportive counselling. The effect of CBT upon suicide and relapse rates, well, there was insufficient evidence when it was compared to standard care during treatment. There was insufficient evidence when compared to standard care at 12 months post-treatment follow-up, and again when compared to other psychological treatments at 1 to 2 years post-treatment follow-up. However, the effect of CBT upon symptoms, there was limited evidence that CBT reduces symptoms when compared to standard care at the end of treatment. More significantly, there's strong evidence that CBT improves mental state when compared to standard care at end of treatment. As you can see, this was graded at 1A. There's limited evidence that CBT reduces symptoms when compared to other psychological interventions at the end of treatment. And other effects of CBT, adherence to drug treatment when compared to non-specific counselling, then there's limited evidence here. There's currently some research going on in that area. Improvements in insight compared to other treatments at 12 months and 5-year follow-up was 1B, and improvements in social functioning when compared to non-standard care, again the grading there is 1B. So the clinical summary then for CBT suggests that overall there's good evidence that CBT reduces symptoms for people with schizophrenia at up to 1 year follow-up when compared to standard care and other treatments. The evidence is stronger when CBT is used for the treatment of persisting psychotic symptoms rather than for acute symptoms. Moving on to family interventions, then we have to look at how this is defined. And this is family sessions with a specific supportive or treatment function based on systemic, cognitive behavioural or psychoanalytic principles, which must contain at least one of the following. The first being psychoeducational intervention, the second being problem solving and crisis management work, and interventions with the service user being the final one. The evidence here was drawn from 18 randomised control trials with data for 1,458 study participants with their families. Comparator interventions included standard care, this was 11 studies, or non-standard care, which was standard care plus general family support, with 5 studies. And the results of this indicated that there's strong evidence that family interventions, when compared to all other interventions, decrease the likelihood of relapse during treatment, again graded at 1A, relapse 4 to 15 months post-treatment follow-up, graded at 1A, and hospital admission 13 to 24 months into treatment, graded at 1A. Further results are that there's limited evidence that family interventions, when compared to all other treatments, reduce the likelihood of relapse in people with persisting symptoms after 12 months of treatment, there's limited evidence at 1B there, and relapse in people with persisting symptoms up to 6 months post-treatment, again graded at 1B. So the clinical summary for family interventions then suggests that overall there's strong evidence that family interventions improve the outcomes for people with schizophrenia, living with or having close contact with their family, most notably in reducing the relapse rate both during treatment and for up to 15 months after treatment has ended. Thank you. That concludes our presentation, and I'll hand you back to Tony.
Thank you, John and Andy. We start the second part of the presentation now, which is the questions from the audience. And for those people wishing to participate, I would just like to remind you of the means by which you can do that. The first is the telephone number, which is 01752 233 646. The second is by email, which is tvstudio@plymouth.ac.uk. So we're open now for people's questions and inquiries. But first I'd like to just start off with a question to the panel. The Schizophrenia Guideline is focused very much at primary and secondary health services. And the point was made in the presentation that the take-up of health services is generally poorer by people with schizophrenia than the general population. How do you feel that the Schizophrenia Guideline might actually help improve this? Who might wish to start?
I would be happy to respond to that. I think that in broad terms, clinical multidisciplinary teams who are providing services for these patients, in a lot of areas they're working in ways which are not very far from the principles and processes that are expressed very clearly in the guidelines, and I think that's part of psychiatric services developing more confidence about what they're doing and more outreach to primary care. It's a part of people who may not be directly involved in mental health work, but see what community mental health teams are doing in primary care settings, are recognising that intervention can be undertaken, and it's important to get going early. That there's a more positive atmosphere around this area. I think that this is part of a kind of general raising of consciousness, which is helpful in this area.
Could I add to that point Mike's made? I mean, I think it's absolutely right. The guidelines say that it's holistic assessment and care that's multidisciplinary, and the implementation of the guidelines should cover the interface between primary and healthcare very clearly. And GPs and primary healthcare practitioners do have a clear role to play in the early identification and treatment of psychotic disorders. And I think there's a couple of things that is worth emphasising. One is that it's not implicit or explicit in the guidelines, but GPs and primary healthcare services should have a register of everyone with long-term mental health problems, which will enable them to regularly review people. And I think that's one of the things that would be good practice that goes alongside the guidelines. The other bit, which I think is an act of faith really, is that underpinning the guidelines there's a clear and explicit recommendation that their implementation is a partnership which is between service users and carers and the people providing the services. And I think if services work towards being a partnership in that way, then service users are much more likely to take up a whole range of services, including the general medical services as well.
I think there's also the issue of care pathways, and once the structures are in place, then the sort of respective health professionals or individuals along that care pathway will be aware of their involvement in the implementation of these policies.
I noticed in the guideline, I think it builds on what's already been discussed, the Schizophrenia Guideline, that there's a recommendation of the use of advanced directives. How do you see those working in practice? Nick, could I pick on you?
Yes, absolutely. I mean, having had experience of clients for whom it's worked well, I think it can be really helpful, which is that people can make some clear and explicit recommendations, documented, in conjunction with their care manager at the time, that says exactly the services that they would like that help them most, so that when they are again having an acute psychotic episode, people are acting from a very informed base on how to implement those recommendations, and it can work extraordinarily well, particularly in terms of people staying engaged with services, and I think that's one of the key things, so that afterwards again they know that what happened is something they had considered, planned for, and was implemented according to their wishes. And I think certainly some of the evidence from the users is that they tend to disengage from services when things are done to them that is not according to their wishes, and that makes them say, I don't want anything to do with mental health services, and again that has problems with engagement and relapse. So they can be very effective in terms of ensuring that partnership at times of crisis.
Mike?
I would agree very much with what Nick has said about that. I think that in my experience, it's been a common part of the practice of mental health teams working in this area at times to use a very assertive approach about preparing people for what may lie ahead and reviewing people's experiences, and I think it's a very good thing that they're expressed so clearly and explicitly in the guidelines. I think that will promote that in a useful way.
I think one of the issues that service users have is a fear, although it's stated in the guidelines that advanced directives will be paid attention to, I think there's a fear from service users that if they have had bad experiences, when they come in again, will they be meeting somebody who doesn't know their experience or who hasn't yet got their notes, and they'll have a recurrence of a bad experience. I suppose one thing that's in their favour may be the development of much more integration between services and the use of electronic patient records that can be accessed from more than one point. So I think it's really getting good practice in relation to service integration and the communication of records that will make this work. But I think there is a genuine fear from service users that bad experiences will be repeated, and that's one of the one of the dangers that we have in terms of engaging with people.
I think just to add, one of the other elements of the advanced directive is that it's something that families can know about and be prepared for as well. So again, they have done the planning and been part of that process, and can be part of the advanced directive in terms of their part in that as well.
I did a quick straw poll amongst some of the staff in the local trust, and they felt that there was a little evidence that there was use of advanced directives within acute inpatient care, but it was more commonly found within the community mental health setting.
Because one of the issues that was raised in relation to the advanced directives was that whilst they might be known about and expected within secondary services, people using either primary health care or secondary acute type health services may not have any understanding of this kind of mechanism at all. I mean, how might that be sort of improved or dealt with?
Well, I don't know if I can immediately answer that, but one of the very important things about this is that the services that people with schizophrenia and other serious illnesses receive are embedded in services that are providing full range of intervention for a wide variety of disorders. So the services need to be kind of flexible and responsive in different ways to different situations. But some of the principles in these guidelines are actually very basic, fundamental things that probably should find expression quite explicitly across the board in our services. So we hope that there's a developing general climate where some of these things are getting picked up as kind of quality issues. There are difficulties about promoting a specific sort of expertise in an area where actually the incidence of the problem is such that individual clinical teams working with general psychiatric caseloads may not come across those things very frequently. So you have to manage and balance the expertise and link it up appropriately. And in different areas that will work in different ways. So in one area it might be a community mental health team that will be doing this work. In other areas you might have the various subspecialisms were mentioned in the presentation we've just seen. So there's home treatment, there's assertive outreach, there's early intervention services, and those are configured in different ways in different places. And I think there's a lot of important issues that we need to attend to in the way these organisations communicate with one another to share their expertise and provide a sort of seamless containing service for our patients.
John, you mentioned electronic records. Do you think there's a big potential there for?
I think there is, but I think what probably underpins what some of what Mike's saying as well is really strengthening the idea of the care programme approach, that we're not talking, you talked about acute services, that we're not talking about the acute service as being a separate service. We're talking about an integrated, Mike mentioned, seamless flow through care. So the person's experience moving through care may be in different settings in which they're getting different interventions, but is part of a planned process rather than separate, isolated instances of care with different assessments, different records, different notes, different individuals involved. But the unifying aspect is the care programme approach. There should be a care programme coordinator who can deal with the transition through these different phases. So although NICE refers to 3 phases, the individual's experience is of one of a smooth, hopefully planned movement through care. And the care programme approach and the role of the care coordinator is no less for somebody who's in acute care than it is for somebody in a community mental health team.
Okay, thank you. To change direction slightly, if I could, to focus on the neuroatypical antipsychotics. One of the issues that was brought up was the length of follow-up that had been involved with most of the studies that were identified. How do you feel that the antipsychotics will be monitored over time, and these issues around comorbidity, how would they be identified and managed?
I can respond to that. There's the world of research and the studies that have supported the introduction of these drugs, and then there's our clinical work, which gives us the opportunity to work with our patients using these medicines, and so now we've accumulated a few years of experience. One of the clear impressions that most people, I think, who work in adult mental health have quite a strong sense of how much better these medicines are, that our patients often are quite enthusiastic about the difference in their own perception of side effects. Not having side effects for many people. Some people get the problems of weight gain and the other side effect that people describe sometimes is somnolence. We don't have very much of a sense that there are a lot of other side effects with these drugs. We're in an atmosphere where we need to be very aware about the way our medicines are affecting our patients. So there's quite a lot of practice where we look at routine blood measures on a regular basis, and I think we're also reliant on a wider climate of vigilance. I think we're helped very much by people who, working in our pharmacy support services. We will gather more information as we go along, but I guess most of us have very positive clinical impressions from the early years of the use of these medicines.
Okay.
And I'd agree with what Mike said, but I also think there are important areas for nursing staff to be involved in, and one is some sort of adequate monitoring and rating of the potential for side effects. I believe somewhere reference is made to LUNSA's, the Liverpool University Side Effect Rating Scale. However, my experience has been that if you look around, then the application of lenses is quite what's the word I'm looking for? Quite patchy. So I think there's a role there. And Mike mentions, for example, sort of weight gain. Well, if we look at issues based around compliance, then if we have better management of potential side effects and the early detection of side effects, then that will, presumably have some impact upon compliance rates. I also think there's an important role here for the pharmacist as well, in liaising between the psychiatrist and the nursing staff in the monitoring of side effects.
Mm-hmm.
Could I just add a complementary dimension, I hope, which in the long term,
Mm-hmm.
I suppose it is this issue between effectiveness and efficacy, and we're going to find out when in 5 years' time users have expressed their views about how satisfactory the new medications are. And in that sense, I suppose we wait and see. That a lot of studies are done on slightly select populations, obviously, and now it's the whole pushing it out to a whole range of people who wouldn't necessarily fitted the original sort of research criteria, and their acceptability to users in that context is still something which we wait and see. And I think it may well be other side effects come up. I mean, I want to travel optimistically, but obviously one's been through a whole wave of new medications all the time, which are successively better than the last, and these are the new wonder things. And so there's just a note of caution there at the same time. And I think there is some evidence of side effects in terms of sexual functioning, anyway, that may again leave people to have some reservations if their relationships are being affected, and if that's a particularly significant part of their functioning in life. So we wait and see, I think,
Yes, I think that's an interesting point you make there about sexual dysfunction as a side effect, because what seems to be the case is that some of the pharmaceutical companies are now marketing their products on the basis of the side effect profile. So whereas one may give you weight gain, it won't give you sexual dysfunction, and vice versa.
But bottom line is people may prefer still to have a sexual functioning than take medication.
Precisely.
And I can think of one patient I can remember in particular who we established on the atypical new medication, and we were all delighted by the improvement in his clinical presentation, and saw him embarking on a new era and being able to cooperate with a new sort of energy into his rehabilitation and so on. And after he left hospital, after a few weeks, he stopped taking his medication and clearly and strongly asserted his wish to go back on the depot treatment he'd enjoyed before. And he absolutely insisted on this. It was never possible to be absolutely clear what his reason was, but he made a choice to return to the traditional medicine, which is quite unusual in my experience, but those drugs are still efficacious and may be helpful at times.
I think that's an interesting point, and sort of leads me on to another question that was has sort of come up. The idea that both the atypicals and what we might call the typicals both seem to work, but the difference in costs of the two is quite significant. And the question really about saying, people so far seem to be pretty enthusiastic about the newer atypicals, but what justifies their usage over the typical preparations that have come so far, particularly as the costs are markedly lower, and then you get this issue about focusing resources.
Yes. Well, that's a very kind of central question, which most clinicians now have a very clear picture of. That quite a lot of people have grown used to using the traditional sorts of medication over long periods of time, and one of our experiences has been thinking about that when you see the person in the outpatient clinic who's been having a treatment which has in some terms been perfectly effective over a long period of time. Do you raise the question of the new atypical medication with them? And it seemed to me that it's become more and more important to think about that, because whilst we may be comfortable with the way things are for that individual, the side effects of the traditional medication can be quite pervasive, and it can be quite difficult to spot. If there are obvious extrapyramidal symptoms that are picked up by ordinary clinical vigilance or something like Lanza's, well and good, but sometimes it's quite a subtle sort of slowing and reduction in movement and responsiveness, and people may say, well, that's a product of that's a part of the unhappy experience of the schizophrenic illness. So our patients, when they take this medication, when it's effective, are likely to have to take it for very long periods of time. And so even quite a minor subjective improvement in well-being associated with taking it deserves serious consideration. And I think for most of us, thinking about those situations, if we identify with that personally, if we think about what we would like for treatment, or we think what our relatives would like, there isn't any question about it that we need to use these new medications. And the kind of compliance issues, I mean, if somebody's compliance means that their medication keeps them well and cuts down, they don't need to miss many days in hospital to recoup very satisfactorily in crude financial terms, in terms of the amount of expenditure that's necessary.
John?
I was going to say, I think if anyone who's worked with the older antipsychotics for any length of time will, or anyone who's been on them, will report that their side effects can be pretty nasty and pretty unpleasant. The guideline is very clear that if somebody's on them and is happy with them and they're working, they shouldn't be changed. But I think there was a danger when there was the choice of the unpleasantness that people were reporting of somehow being minimised by health professionals because they didn't see a choice. In other words, they saw, unless we reinforce that this person needs to continue on this medication, they're going to stop it. So there was a tendency, and I think many people have been guilty of it, of minimising the subjective experience of the client and saying that they're, trying to tell them that the side effects weren't as bad or weren't as unpleasant as they actually were. And I think one of the things that the guideline does, first of all, it eliminates the kind of postcode lottery of the experience of service users depending where they live. The guideline says very clearly that if you have side effects which are troublesome, then you should be offered a new atypical. Now that was a choice that wasn't available or wasn't available everywhere until the guidelines came out. So I think although it may not be such a dramatic change, the shift is going to come that suddenly service users feel that this is on their side. They're actually going to be asking for something rather than asking not to have something.
And just following John's point, I think, again, from the user's perspective, some of this will be driven by them, and they will have the information that's readily available in terms of these new forms of medication that may be helpful. So if they're having problems, they will be hammering at the door and saying, can I have a trial of this as well? And one of the nice things about NICE guidelines is it's saying, actually, this is what's recommended. So having done their appraisals and their cost-effectiveness appraisals, they're saying, yep, this is what should happen, this is good practice, which means the money should follow on from that. And if they were to have said, no, actually, we think these are too expensive given the minor improvements, then I suppose we'd be in a different situation. But again, just emphasising the user's perspective, that if they had been subjected to horrendous side effects, tardive dyskinesia and the rest of it for many years, they will hopefully be saying, look, enough of that, I want something that enables me to get on with life in a much more effective way.
Right.
I'd be interested in Mike's views in the comments and the recommendations about consultation between the individual and the psychiatrist about the choice of medication, because again, the anecdotal evidence I have is that there's little evidence in some units that this actually takes place.
I hope it takes place a lot in the areas that I work in. I have the opportunity to have a look at the functioning of a variety of different sorts of teams. Several of the kinds of team that are mentioned in the advice are represented locally. And I think there's quite a strong culture which is developing towards explicitly negotiating in much more open ways than what was common previously. I think that that being specified in clear ways within this document, I think that the appendices of the documents which provide information which can be which is designed to be easily understood by lay people and carers and patients is excellent statements about principles that are gradually getting to be quite commonplace in lots of psychiatric teams, so that in those areas where the what we would regard as appropriate levels of consultation are not taking place, then I think that as clinical governance sort of takes on the project and the issues here in local areas with audit projects and so on, it's going to raise the profile and it's going to provide some direction towards positive changes in practice. That's good.
Nick, I was just going to try and bring you in on a slightly different question, in the sense of the relationship between, in the guideline, between the use of the atypicals and psychological therapies and family interventions. If you've got a particular sort of...
I think it's interesting because they're both recommended and the evidence is clear for both, but obviously we're talking about the implementation of the antipsychotic medication rather than the implementation of the psychosocial interventions. Just before answering that, one of the other angles I think on the cost factor is that often it comes down to persuading GP colleagues who end up having a very limited budget to meet the costs of expensive medications that have been prescribed by consultants or inpatients and so on. I think there's still an issue there, and many health communities do find themselves considerably overspent because of their rising costs of the drug budget. So that is something that needs to be thought of. Within psychosocial interventions, it would be nice to think that there was money that would be equally clearly put aside for implementation of the family and CBT interventions. Sadly, I don't think that's going to happen, because it's going to be much more ways in which we can implement training and influence cultures and implement what we've learnt from training programs, links between universities and health communities in that respect. And it's going to be a gradual process of skilling up the workforce and allowing them and enabling them to have the opportunity to work in that way, and particularly to continue in the direction of working towards working with families and communities in a recovery model. And some of that, I think, is an attitudinal change as much as a resource change. But having said that, the amount of money that is spent on researching, training and implementing in psychosocial interventions is a tiny proportion of the amount of money spent on the drugs. If we had a tenth of that, I think we would have a revolutionary mental health service.
Right. Anybody want a quick follow-up on that particular point?
Well, slightly allied to that, it's having seen the recommendations and the number of trials, then it's to what extent the activity within the Institute of Health Studies, or what becomes the Faculty of Health and Social Work, is possibly driven by the research agenda.
Right, we're nearly to the end of our seminar, and thank you very much for participating. Some very insightful comments and thoughts, and hopefully our audience has enjoyed it as much as I have. Thank you very much. Anyway, thank you, and it's goodbye from the studio, I think.
Guidance. First of all, in the original implementation guidance for the National Service Framework, and then a series of other specific guidance, or PIGs as they've become known, around specific services, such as services for women, acute inpatient services. So, as I say, the two documents we're looking at, first of all, the technical appraisal of the atypical antipsychotics, and then more recently, this first clinical guideline that's been released by NICE on schizophrenia. If you haven't got the documents, you can download them straight from the internet from the NICE website. You can order them from the NHS response line, or you can order them by email from the Department of Health. So the question is, can we make these policy initiatives, these policy implementation guidelines, a reality? Let's look a little bit at the background to schizophrenia and some of the outcomes. Perhaps the least publicised is that in fact something like a fifth to a quarter have a single diagnosed episode with no resulting clinical or social impairment. Something like 35% have occasional recurrences with no or minimal impairment between.
Hello and welcome to the studios. This is the latest in the IHS research series, and today we're going to look at two clinical guidelines from the National Institute for Clinical Excellence. The first guideline is the use of newer atypical antipsychotic drugs in the treatment of schizophrenia. The second is core interventions in the treatment and management of schizophrenia in primary and secondary health care. I'm joined today by four colleagues from the local health community: John Rawlinson, Andy Carbery, Mike Snelson and Nick Booth. Each will give a short introduction on their interests and activities before the presentation starts. John.
Yes, hello, I'm John Rawlinson. I'm the academic lead in mental health within the Institute of Health Studies. My background is as a CPN. I run the qualifying course for CPNs, the Community Healthcare Nursing course for mental health, and the MSc in mental health.
Or alternatively, you can email on TV Studio, that's just one word, at plymouth.ac.uk. Well, without much further ado, I'm going to ask John to begin the presentation. John.
Hello. The presentation today concerns two documents from the National Institute for Clinical Excellence. The first is the new clinical guideline on interventions for the treatment and management of schizophrenia, and the second is a technological appraisal, which is guidance derived from looking at a specific intervention, the newer atypical antipsychotic drugs. First of all, I'm going to give an overview of the guidelines, and then Andy Carbery is going to review the evidence that underpins them. I'm going to start off by talking a little bit about the context of these guidelines on schizophrenia, starting with a reminder that the care programme approach has been the underpinning way in which mental health care has been delivered since 1990, although it was implemented a little bit later than that. We had the initiative The Health of the Nation in 1992, which tended to focus on severe and enduring mental illness, and in particular suicide risk.
Hi, my name's Andy Carbery, Senior Lecturer in Mental Health based in Taunton. My particular interest in the topic today stems from some involvement in medication management in psychosis and the subsequent development of some courses to cover that, and in cognitive behavioural therapy, which I'm involved at the post-registration level.
I'm Mike Snelson. I'm a consultant in general adult psychiatry in Plymouth, and I work as the senior medical member of a community mental health team, providing in psychiatric interventions for a sector which is about a fifth of the population of Plymouth.
Hello, I'm Nick Booth. I'm Head of Psychotherapy Services in Plymouth Primary Care Trust, and by profession I'm a clinical psychologist and family therapist.
The session today is in two parts. Firstly, John and Andy are going to provide an overview of the two documents we're discussing, and then there's a discussion involving the audience in the various centres that receive this broadcast. For those people who wish to participate in today's broadcast, I have a telephone number which is Plymouth, which is 01752 233 646.
There have been various attempts to provide guidelines for the treatment of schizophrenia. There was an attempt in 1995. The Clinical Standards Advisory Group provided some guidelines on schizophrenia. They've been developing a body of evidence in relation to some of the interventions which are included in the guidelines, and these are family interventions, psychosocial interventions, developments in pharmacology, in early intervention, and in assertive outreach. These have been going on prior to the guidelines. We're in an era of evidence-based practice, evidence-based medicine. I guess the last decade has perhaps characterized an emphasis on this aspect. It's been characterized by the release of various effective healthcare bulletins, Cochrane reviews, contributing to the evidence. And then we had the National Service Framework for Mental Health in 1999, which started to set out the standards which would be provided within mental health services. The British Psychological Society contributed to our understanding of the experience of psychosis by a very useful document which summarized the understanding of schizophrenia and psychosis. And then we've had a range of mental health policy implementation